Good evening, everyone, and thank you for joining us. My name is Carver. I'm a product specialist here at Oculus, and welcome to tonight's clinical webcast, Keratograph 5M cheat sheets, work lists, interpretations, go-to treatments, and the verbiage to explain it all. You have a text box on your GoToWebinar screen where you can enter in questions. Enter your questions at any time, and we will discuss them at the end of tonight's webcast. Our speaker tonight is Dr. Crystal Brimer. Dr. Brimer is an expert on dry eye and runs Dry Eye Equation in North Carolina, a practice that focuses exclusively on dry eye. She is the main mind behind the Crystal Tear Report, and as such is the perfect person to explain exactly how to use the Keratograph 5M in a clinical setting. If you want to learn more, I highly recommend checking out Dr. Brimer's Dry Eye Institute and attending one of their weekend dry eye retreats. Dr. Brimer, take it away.
All right, thank you, Carver. I appreciate it, and I appreciate being here tonight. Excuse Daisy in the background. If you've seen me in the last year, Daisy usually makes an appearance at some point, so tonight is no exception. Now, she's eating her bone right now, so it was either that, and you hear a little chewing in the background, or, she ends up right here, full face front. I hope it will be valuable. It's going to be jam-packed. We don't have a lot of time together, so I want to make the most of it. Here's my plan to go through the interpretation, just little tips as far as what you're seeing and how to get better images, what it means, and then my cheat sheets, the work list that I use, my good, better, best cheat sheet, and then my follow-up protocol and flow sheet. And then we'll wrap it up with some verbiage, how I set up the exam for the patient and kind of set their expectations, and then how I do the wrap up and explain to them what I'm seeing and what treatments I want to pair with their problems. So starting out with the interpretation, my first test that I do on my full dry eye eval is the tear meniscus height. And the thing I would say to you as far as capture is don't let the conjunctival chalasis fool you. When you look at this, this is an example of obviously a low tear meniscus height. I ideally am shooting for 0.3 or higher. This is a normal one because we're above 0.3, but down here, and even here you have to be careful and say, okay, look at the amount of volume here laterally, and hopefully you can see my mouse, but I'm on the lower image on the left-hand side, and I'm looking temporally. The reason I always personally measure it in the middle is because I'm gonna have more conjunctival chalasis laterally. So I don't tend to do the 3 measurements and kind of average them. I really look at that and try to find the detail and make sure that I'm measuring just volume, just tear meniscus height and not chalasis. Now down here, this person has epiphora, so we've got an over tearing situation, which is also abnormal. And then here on the lids picture, this is the next one in my collage when I'm doing my dry eye eval. And I want to be able to show the patient, all right, here's telangiectasia. This is ocular rosacea. Here's blepharitis bacteria on the lid margin. Up here, we've got more blepharitis. Now, in these 2 images, they happen to have been taken after the lysine green, so they've got a little bit of absorption there. And then down here, this one's pretty normal looking. I always appreciate that. And then here, just another one with significant rosacea and backed up meibomian glands. And then my next image is going to be interferometry. And here's an example of one without color and one with color, obviously. And the way I explain this to the patient is I want to see a rainbow on here, a prism effect, just like when it rains outside on a greasy spot. I want to see that rainbow. When I don't see it, it means that the oil is not exiting through these glands easily with the blink. And I explained to him at this point why the blink is so important, that these glands have a sphincter around them and that it's not releasing the oil until those lids touch. And then I go into my fluorescing video. On this one, you really, when you've got a technician doing this, you really want to make sure that they are aware of what you're trying to do, what you're trying to see. You want enough dye in there that it's going to show up the breakup time. You want some natural blinks before you start the video so that you can slow it down and see partial blinks if they have that. And you want to wait long enough for the capture that if they're staining, you're able to see it. So here we got some great examples. This one is pretty normal, maybe a little bit shortened breakup time, but not bad. And then here in the middle, you see we've got exaggerated blinking, but we've got a very quick breakup time. As soon as they open, those tears are not spreading well to begin with, but then we see the breakup happening. And then here, obviously, we've got inferior conjunctival staining. You can also see all the debris in the tear film. I like to use my fluorescing videos, again, to slow down and show partial blinks, but it's a great way for me to show I'm scalloping on the lid margin. I mean, you can see on this right one how unhealthy that lid margin is and the staining. You can see in the middle one the scalloping, thickening of the lid. I can always show them whenever I have lower lid lag. And again, discharge is going to be able to be visualized much easier, especially when they have the long, stringy allergic mucus, because that's often clear and it can go undiagnosed or just missed. But when you have that dye in there, it all of a sudden becomes very obvious and somewhat offensive to the patient. So when they see that, they want to do something about it. They want to fix it. And then my biography, I do my uppers and lowers. Sometimes if, depending on who's capturing the images, they may only feel comfortable doing the lowers. We use the lid stick in our office, and that's helped tremendously on getting my staff ready and able to do the upper lid inversion. This one, pretty good. Here we've got loss nasally, and you can see anywhere there's black lines. So even right here where my arrow is and these vertical lines in the middle of the glands, anywhere there's black, that's blockage. A lot of times I'll see horizontal blockage here, and then you'll see just basically where we lose that cylindrical shape. Sorry about that. We lose the cylindrical shape after the blockage. So just like in these, we kind of lose definition. You're not sure where the gland is. A lot of times that's because there's blockage in the middle of the gland, and basically if we fast forward 6-12 months, we probably won't see that tail end of the gland. That's when the body is basically cut it off, and it's going to end up getting reabsorbed. Up here we see space in between them. So we know we've lost some glands, and that's what allowed us to have space for it to curl up and become telangiectasias. And then over here we've got loss. And this is one of my extreme patients. This was just the other day, actually. Nothing, really no glands on the bottom. We just have 4 or 5 up top. And when they're this skinny, it's hard to say if we'll be able to really recover function out of those glands. And I will say I've been surprised before. Here, I really enjoy doing my tear film dynamic at every visit. And I do this because it just gives me a snapshot, a status of how much junk is getting in the tear film. And most of the time, this is going to be correlated to how red the eye is. The more toxicity there is in the tear film, the more red the eye is going to be. And the patient's first response is always, okay, where is this coming from? And basically, I rule out each of the common culprits for this. So I debride the lid margin every single time. And if I'm getting a lot off, then sure, that's going to be one of the big sources for this contamination in the tear film. So we look at like this one over here to the right. That patient probably has some scurf, some biofilm on the lid margin that would have been visible whenever I debrided the lid. Other big sources, if I've got meibum that's thin enough to come out, but yet it's not clear, then that's going to be another source of this debris. So a lot of times, if a patient has meibum that's semi-solid, they're not going to have as much debris in the tear film because it's not exiting, it's not reaching the tear film. But when we get a little bit more liquefaction of that and we look at it and we squeeze and we say, oh, things are getting better, but that's sometimes when I'll have a more contaminated tear film and maybe even have more corneal staining because of that toxicity. And then other sources, allergic mucus and debris. And of course, if a patient has a really low tear meniscus height, tear volume, they're going to have a more hyperosmolar tear film. And so you're going to see a lot more floating around in the tear film. Redness. My advice to the person acquiring the image, focus on the lashes and then push in slightly. If you look at all these, I want my lid margin to be in focus as well as the conjunctiva. And so if I have my technician just focusing on the vessels and the conjunctiva and the sclera, sometimes this is going to be quite a bit blurry. I want to have that range of focus where it includes the lid margin, includes the conjunctiva. But if they're out here and the tips of the lashes are in focus, and then I tell them, all right, look at what's in focus. If that's what's in focus, you've got to push in. And really for my redness scan, that's my best starting point anyway, is lashes and push in. I absolutely love this picture and I rely heavily on it because it tells me so much more than redness. I'm looking at the lid structure and I can show the patient. So for instance, this one on the left, this is a good lower lid tonicity, but on the middle one, you can see there's the lower lid lag. You can see it's even more exaggerated on the one on the right. We can see dermatochalasis on this one in the middle, completely covering up the lashes. Ectropion, if it exists. We can definitely see the lid thickness, and I love showing the patient on this picture. And a lot of times I'll even show them the difference in the skin color. So when they have these vicious red lid margins, I'll come out as far as I can over here and I'll say, see how different this color is, look at this contrast. And I can really show them the ocular rosacea, hyperemia, telangiectasia on the lid margin. So very important acquisition item for me in my patient education piece. And then lastly on my collage is my lysine green images. You want a nice thin line. If you don't have some sort of absorption here showing you that mucocutaneous junction, then you don't have enough lysine green in there. So I tell my technicians, dab it, basically pat that or tap that lysine green strip along the lower lid margin, and then have them close their eye gently, open up, make sure you've got enough. And then here on the right, you see that we've got a little bit exaggerated lid wiper epitheliopathy. It's not bad, but I explain this to patients as this is my windshield wiper. And just like if you run it on a dry day, it's going to dull that blade. Same thing happens here. This is friction, and that's caused the changes in the cellular structure along the lid margin. And this is the person, especially the more exaggerated this is the person that when they blink, their tears are not spread well. They're already just basically an immediate breakup time because it's not working the way that it should as far as the spreading the tears and being that gatekeeper, that windshield wiper for the ocular surface. And then down here at the bottom, line of marks. And this is a pretty significant one. I would say this is moderate to severe even. You're looking at a lot of things. You're looking to see, does it cover up the glands? If it covers up the glands, it's very unlikely that you're getting meibum out when you express. But the folks who have more staining, they always have more biofilm, more bacterial elements to it as well. So those go hand in hand. And then now that we've kind of talked through the interpretation and want to look at, okay, how do we put this into our clinical practice and make it as simple as possible, but also as consistent as possible? The goal with dry eye, one of the goals, is to be able to do it well and thoroughly without increasing your chair time significantly. And that's a challenge. It's a lot of the feedback that I hear from doctors is, oh, I want to do dry eye, but it takes too long. Well, the 5M, when utilized well and really maximized, is the tool that will shorten the time, not extend it. But this is a key factor. You want your staff to become empowered and to really to have excellent skill with the 5M, but not just to help speed your exams and make them better, but really to help them own their position and take pride in what they do. And I've seen this direct correlation over and over again. Now, one way to get them there, the 5M allows us to do saved work lists. And so when you think about this, if I have a corneal eval because the patient's had corneal staining habitually, I want a different set of tests done than if I'm bringing them back for a blepharitis follow-up, or if it's just a regular dry eye follow-up. So if I have these things laid out ahead of time and on the schedule, it says K eval, K check, and she goes into our OCULUS 5M and she pulls that up, we're going to be on the same page. She's going to feel like she's doing a good job. I'm going to get what I want. And then the other thing that helps her be very successful is this example image in the capture screen and the advice. So this is really important. Show them this, help them to make sure they're continually referring to it. We're training a new technician now, and I tell her every single time, when you have your capture, I want you looking at that picture and saying, all right, how's mine compared to that? And so it keeps us from having to be in the room continually coaching her. It gives her a resource and a reminder. And here's just some examples. So here's our example image on the LWE, the lid wiper epitheliopathy, and the line of marks, our upper lid image, and then here on the redness. And it just really, again, solidifies the end result for you, but also their buy-in. So here's a quick little video on how to do this in your 5M. Go up to settings, go down to customization editor, and then as you scroll, so first of all, pick your report that you want to go with it, name it. But as you scroll through the things on the left side, the assessment items, it's going to automatically highlight the correlating capture items on the right and vice versa. So this way, you know, all right, if I want to grade, corneal staining, what acquisition items do I need? And then if I add in upper lids, what all can I find out from it? And you see now that K-check is right there because we saved it. So here is my full dry eye eval. It's everything we just talked about in interpretation. It's the tear meniscus height, the lower lid image, the upper lid image, interferometry, fluorescence video, mybography, tear film dynamic, redness, and lysine green. This is a full dry eye eval. It takes us about 12 minutes to get all of that done, and that's including both sets of dyes. If I want to do something quicker, then I do the mini dry eye eval. So going back one, sorry, this is my full dry eye eval. Tear meniscus, nick butt, tear film dynamic, lipid layer video, topography, etc. Now, the only ones that aren't in that collage that I just take because I still want them, even though they're not in the collage, the nick butt, the topography, I don't bill for it unless there's a reason, but I take it on everybody. The line of marks and the upper lid staining, and the fluoro inferior palpebral conjunctiva, and also the white picture on the upper palpebral conjunctiva. So again, those aren't in my collage, but I like to be able to refer to them just on that initial dry eye eval. Now, let's say you don't have that much time. You've got 6 minutes. Here's the mini dry eye eval. And there's really nothing extra over here except the inferior conj and the topography. Everything else that you're doing is showing up over here on the collage. And really it's the same thing, except we got rid of lysine green. And that does save a lot of time. So I've got an incredible amount of information still. And ultimately, if the conjunctival staining was bad enough or the lid margin staining was bad enough, I'm going to see it with the fluorescein. So I don't feel like I'm missing a lot of information. So if this works better for your practice, do it. Trying to see, I thought I had that written out for you. Now, my cheat sheets for my follow-ups. The basic dry eye follow-up is right here. I want to know water, oil, inflammation, and just, I call it just kind of toxicity. I want to know what's in the tear film. So I do my tear meniscus height, interferometry, redness, and tear film dynamic. And this is done on every single dry eye eval. So if I didn't put in my notes of why I want them to come back, if I didn't specify that it was MGD, K-eval, or blepharitis, then I know this is what I'm getting. Now, for my MGD follow-ups, we add the nick butt to that. And that's primarily for patient education piece to be able to show them that it's getting better. For my K-evals, we add the fluorescence video so that I can see the staining. For my blepharitis evals, or follow-up, sorry, we add the upper and the lower images. So again, here's my basic, and that's tear film dynamic, or sorry, tear meniscus height, tear film dynamic, interferometry, and redness. Now, just a really quick side note on billing. In order to bill photos, it is supposed to influence your medical decision making. Well, if you think about just billing from an anterior segment camera and you're just showing what you see, kind of like this one, is it really influencing your medical decision making? That might be hard to argue. When I use my 5M, I'm measuring my tear meniscus height. I can't do that at the slit lamp. I'm seeing the oil in the tear film through the interferometry. Can't do that. And then I'm getting an actual redness score that's automated and, you know, able to be tracked over time. So I feel very justified and valid in doing these 3 tests and then billing those anterior segment photos on every follow-up. And then I do the tear film dynamic just for kicks because I want to know. K-eval, same 4 tests, but we added the fluorescence video. Blepharitis follow-up, same test, but we added the upper and lower lid images. MGD follow-up, same 4, and we added the non-invasive keratograph breakup time. Now, I love this test for the purposes of just patient education and correlating the oil content to the vision, because I could say, okay, see how these rings are getting distorted. This is the tear film breaking up. This is why your vision gets blurry and you have to blink to see better. It's why you start to burn. And it just makes sense to them when they're able to see that. Now, so moving from interpretation and then our work list, and really, again, how do we put this in play in the office without taking up extra time? How do we explain it to patients in a way that doesn't overwhelm them and doesn't slow us down? First of all, when we're talking about setting the stage, before we ever get them back for a dry eye eval, we've got to identify them. And so I highly, highly, highly recommend and just challenge you, screen every single patient. Now, even when you have a keratograph, you could choose any way you want to screen them. I certainly have my preferences. Now, before we had a keratograph, we just asked these 4 questions. We didn't use a speed or an OSDI just because of the time that it took. And we didn't even have this written down. My technician had it in her possession, and she would turn it over to him when she was doing the autorefractor and everything, and she would say, hey, would you answer yes to any of these questions? Now, then we had a follow-up protocol after that. But if you fast forward, not very long, it was probably 6 months later when we had the keratograph, this is what we started doing. We started doing tear meniscus height, non-invasive breakup time, and redness. And we did this on every single patient, and they've got this crystal tear screening report in their hand immediately. So it takes 2 minutes from the time they put their chin in the chin rest here until this report is printing out. Now, if you don't have 2 minutes and you need it in 1 minute or less, which is a reality, you can change the non-invasive breakup time, take it out, and put in interferometry. Regardless of which one you use, you still have a snapshot of water, oil, and inflammation. And this, again, is important to me in feeling like I've got the information I need to really know what's the patient's status. Now, I want you to visualize something for a second. patient A had the 4 questions, or they had the OSDI, or they had the speed questionnaire. That was their screener. If that's what you're doing, I'm proud of you for doing something, because in most rooms when I'm talking to doctors, most people don't have anything that they do consistently. So if you're doing anything consistently, congratulations, kudos to you, that's good. But I want you to play this out in your mind of patient A having the questionnaire and patient B having what I just showed you with those 3 tests, and they are handed this crystal tear report. You walk into the exam room and they've been sitting there reading it. Those 3 pictures are on the screen, and patient has the report in hand and they're going, hey doc, what's this? What this means is that patient A, if you say, oh yeah, you've got all these symptoms you listed out, and I see things that concern me, I'm gonna need you to do some warm compresses and some lid scrubs and get these 3 masks, and I'm really gonna need you to come back and have some thermal evacuation and some IPL. You know, it's gonna cost a couple $1,000, but it'll be worth it. That's patient A versus patient B, who you walk in, the pictures are on the screen, they've got the report going, hey, what's this? You look at the screen and say, oh yeah, I see some things that concern me. Let me take another look. You do the slit lamp, and now you say, listen, I'm gonna need you to do A, B, C, and D. The difference is this: the first patient believed that whatever you gave them or recommended was based on their symptoms. And so they either say, yeah, you know what, it's not that bad, or they do it, they feel better, and they stop, because they believe that it was based on the symptoms. Patient B, who had the crystal tear screening report, they understand that it's based on objective findings. And so your recommendations don't have, they're not dependent on the symptoms. They wouldn't be less if there were less symptoms. And that means that it's necessary. It's not something they can say, oh, I'll just tolerate it. And B, it means that even when they feel better, they need to continue the treatment. So just think through that impression that the patient gets. And then as far as bringing them back, I challenge you, don't try to do it all in the same day. Do that screening, and then if you had brought them back in the same day, same thing. Patient feels better, they don't return for their dry eye eval, or they return but they don't see the value because you already gave them the treatment on the first day, and so it's poor buy-in. Or you gave them something on the first day, they don't feel better, and now they don't return because they don't think you know what you're doing. So either way, this is just not a great scenario. And ultimately, we want their outcomes, but sometimes we have to speak their language. We have to do it in a way where it's gonna feel like it's their idea. You know, it's gonna make sense to them. Now, the other scenario is you brought them back for a dry eye eval after the screening. And with this, we started from scratch. We looked and we found everything that is contributing to the problem. We explained it to them in a way they understood it. We wrote it all down. And now we've got the buy-in for the treatments. They get the relief. And this is going to lead to everything we always talk about with the outcomes, the referrals, and the growth. So try to resist the temptation to do this on the same day. Definitely bring them back. And then here's my cheat sheet on what do we do when they get back. Well, we scheduled them. I only do 2 per day, and I do them the last appointment before lunch and the last one before the end of the day, so there's plenty of time. Their questionnaire, all their information is pulled ahead of time, and then the technician's going to do the workup. She's going to do everything you do in a follow-up as far as, you know, VAs, pupils, EOMs, confrontational fields, but she has a list of her acquisition items for the 5M. And then we have patient education prepared ahead of time, so we're not running around digging for it. I walk in and I tell the patient what I'm going to be doing, what to expect. Then we go through the findings. I explain to them their good, better, best options on treatments, and we decide together. Now I give it back to my assistant, and she does the coaching. She makes sure they understand how to do it and makes herself available for later if they have questions. Why do we do it this way? We do it because patients want to know why. And so it's my goal to make sure that I've walked through the explanation in a way that makes total sense to them, and I give them whatever time they need for us to get there. And then we give them that patient education piece to back it up at home. So as far as setting the stage and really explaining to them what I'm going to do, I tell them, all right, today is different. I know you've had this a long time. I understand your symptoms. I understand what you've tried, but today is about the diagnosis. And so I want to draw a line in the sand, and we're going to look at everything that could possibly be wrong. Is there enough water, enough oil? Is there allergy, inflammation, bacteria, lid function, something systemic, something environmental? I'm going to do tests in every category. Whatever's positive, we're going to pair it with a treatment that I know works. Now, the caveat is there's probably more than one thing wrong, and we need to treat them all at once. If we don't, it's going to be a Band-Aid. It's going to be like everything else where you say, oh, that didn't work either. But if we do that work and we treat it all at once, when you come back, I'll look at these categories again and I'll show you, and we'll be able to back off on the things we're winning and upgrade any area that we're not winning, not succeeding at. My goal for today, figure out what's wrong and show it to you. Make sure you understand, and then I'm going to give you good, better, best options, and we're going to decide together. And I do that because everybody's goals are different. Some people want it fast. Some people want it easy at home. Some people want it more natural. Some people need it to be less expensive. I can do any of those, but I can't do them all because they fight with each other. And then the last thing I'll tell you is that it will all be written down. You don't have to remember anything. You're going to get this fancy report that tells you every test we did and then what treatments are paired with those in particular issues and a definition of all the tests. And what the reason this is important, so it's a minute and a half spiel at the beginning. It's important because the patient is typically a little bit anxious just showing up for this kind of appointment, and they don't know what to expect. And I need to tell them that they're going to get answers, that we're going to decide together. I'm not selling them anything, and that it's all going to be written down. Those are the three things. Today is going to be different, and here's why. And so I challenge you, if you're using the 5M for dry eye eval, go through that, set the stage, because you'll be amazed at just the patient's demeanor and how much more open and really just how much better they're able to absorb what you're telling them, because they're not stressed about, oh, are you trying to sell me something? Oh, I can't remember this. And these things that people are just naturally going to gravitate towards. So communication is critical. It's going to create an opportunity for us to have compliance. And when we've got compliance, we're going to be able to get the outcomes that we want. And with the outcomes, we're going to have the growth, the referrals, and everything that comes with it. And quite frankly, you get the outcomes, you're not going to be able to stop these other things. So you've got to be ready with your practice logistics, because it's going to happen. I've heard it over and over again. For me, this is my method of how I explain this to the patient and how I get that buy-in, and it works beautifully. They appreciate it so much, and it just creates an environment where I'm fulfilled with what I do. I'm not selling them anything. I'm just the messenger, and my staff feels the same way. And I know that's a challenge in most offices, is the out-of-pocket expenses of treatments. So it really helps that on all sides. So the last 15 minutes or so, I wanted to spend pulling this all together of, all right, if this, then that, but also how do I explain it to the patient? So we talked about setting the stage before the exam, but I want to talk about now we've got the acquisition. What do we tell them? How do we interpret that in a easy to understand kind of a package with a bow on it? Now, here are my go-to good, better, best. It's not everything that's out there. It's what I've found to be most effective. You might have other things that you believe in, and that's fantastic. Make your own list. It's important that you and your whole staff kind of know where you stand on things and what your go-tos treatments are. So once you make something like this, this helps you get your mind around, all right, this patient's got an oil problem. How do I present this? And so, for example, if I've got an oil problem, all right, you've got an oil problem. Here's your good, better, best option. Good is going to be lifestyle. It's going to be everything we talked about on the diet, the hydration. I'm going to get you a good medical grade nutraceutical, and a warm compressed mask that lasts, one that meets the study criteria. It's 15 minutes, 104 to 110 degrees, and moist heat. So that's good. Better, there's a little handheld device where you spend a minute, minute and a half, and you're able to massage those glands and get the oil glands more motivated, get the oil moving. And then best, hands down, this is going to be a device that heats underneath and compresses on top, and it helps milk those glands. So I'm giving them these options. Now, at that time, I'm also going to go through the other problems. So I'm going to say, all right, you've got an oil problem, you've got an inflammation problem. That's your oil, here's the inflammation, good, better, best. Good is going to be the same. It's a lifestyle, it's diet, it's stress mitigation and anxiety and better sleep and reducing any systemic inflammation. It's the nutraceutical. Better, I don't know if it's better, but it's more aggressive, is all the drugs. So your Cequa, Xiidra, Restasis, there's a nasal spray now, blood serum tears made from your blood, there's steroids, there's antibiotics. And then best, hands down, there is an in-office procedure. It's a light procedure that helps reduce the inflammation. And we're basically, if the face is the tree trunk and the eyes are the branches, we're able to treat it from the tree trunk, so we're not spinning our wheels as much. So bottom line, whatever their problem is, I'm going to prioritize it, and I'm going to say, all right, here's your good, better, best, good, better, best. Now, if it were me, I would do this, 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 and this, and then I wrap it up for them. So this is one way to explain it to the patient. And I've kind of sat here for a minute so you could see everything on the list. Another option is simplifying. If I have a patient who that's going to be too much information for them, then I'm going to do it differently. I'm going to walk through all their pictures and I'm going to say, all right, we've got an oil problem, we've got an inflammation problem. And then down here, we got a little bit of a bacteria problem. Here's how we can handle this. We can work on your lifestyle. We can get a better diet with more fish in there, more hydration, better sleep. We can work on things holistically at home with supportive therapy like warm compresses and lid scrubs and things. We can write prescriptions for blood serum, Cequa, Xiidra, Restasis, blah, blah, blah. Or we can do in-office procedures that take some of the pressure off of you and really get us there faster. In your situation, here's what I would do. Medical grade nutraceutical, I would do this at-home exfoliation device after a good warm compress, and I would do an IPL in the office so that we can potentially stay off of the prescription drugs. So really, as far as explanation, it depends on who the patient is and how you think they absorb the information best. Regardless of how I explain it, they all get the report, shows them what tests we did and what the outcomes were, and then the treatments that are going to be paired with it, the explanation of the test, and then finally a summary of all the treatments that I'm asking them to do. This also goes to the referring doctor. Now, in my practice, once I've made my notes in my EMR, I tell my assistant, all right, I'm out. And she goes and she says, she takes whatever I recommended and how I graded everything, and she grades the crystal tear report for me. And then that is printed out, it's waiting up front when I get up there with the patient. It also goes out that day to the referring doctor. Now, that's one way to do it. Another way, though, because sometimes she's not around, I will review the findings with the patient, and I will sit there and click while I'm talking to them. So I'll say, okay, as far as inflammation, and I'll click on inflammation, and I'm able to show them all the pictures that have to do with inflammation, and I'll just go ahead and grade it while we're sitting there. And then we decide on the treatments, and I run back through and click those, and we print. That is an amazing way to do it as well. So it just really depends on your practice and your flow as to whether you want to grade it yourself as you talk to the patient, or if you want someone else to do it. And do you train them to do it, or do you just have them look at what you've notated and documented in the EMR? No wrong way per se, but I think it is a very important tool to send them home with. And it's something that differentiates your practice significantly. Now, let's walk through, I've got 4 or 5 of these of just example scenarios from my database and what I'm diagnosing them with and how I'm explaining it to them. So in this scenario, I told you we were going to find out, is there enough water, oil, allergy, inflammation, bacteria, lid function. So when we look at this, you're definitely low on water. When I look at your lid margin, I can see this vascularization there. We've got a little bit of rosacea along the lid margin, and you can see it really well on the top lid, but more importantly, maybe there's a lot of bacteria here at the base of the lashes. Now, these little glands are oil glands, and they should be putting oil out into the tear film, but you see here there's not any oil. Now, I know that because it should be colored, just like a little rainbow prism when it rains on a greasy spot. So we're not getting the oil out when you blink, and that's affecting how quickly your tears evaporate. Your tears right here are green, but you see these black spots that pop up immediately. That's evaporation. Now, the real risk and the problem is that these oil glands, they are somewhat fragile. If the oil is not moving out, it can't go back in. It's a one-way street. And so the body starts to dry up the oil gland because there's basically nowhere to put it. And so we see here how some of these oil glands have shortened, some of them have dropped out. And while we can't get those back, we can get rid of the clogs and get these moving again so that there won't be that signaling to lose the gland. Now, here you see there's a bunch of junk floating around in the tear film, and that's creating this toxic environment. It's adding to the redness. And you also see where the lid is coming over those lashes, and that's adding to this bacterial situation. So ultimately, I've got a little bit of a problem with the structure of the lid. My primary issue is really some inflammation, an oil gland issue, and bacteria. And so when we walk through what we can do about that, bacteria, good, better, best. Good is going to be a foam soap, better a hypochlorous acid and a different kind of foam that's stronger, more specific to this type of bacteria. And then best is going to be this little handheld device that exfoliates the lid margin. Oil gland, good, better, best. Good is going to be the lifestyle, the nutraceutical, the warm compress. Better, this little handheld device. It helps massage the oil glands, get it moving. And best is an in-office procedure that basically just evacuates those glands. And then inflammation, good is the same as the oil glands. Better, all the drugs and the drops. And then best, an in-office procedure that reduces inflammation. It's a light procedure. We do it 4 times over the course of 3 to 4 months. Now, if it were me, here's what I would do. I would do the nutraceutical. I would do the light treatment. I would do the little in-office handheld device. And that's not going to take a lot of work on your part. We're going to do most of it in the office. The only downside is that insurance doesn't cover it. And that's basically how I would explain it. It doesn't take long, but it gives them a full understanding and then give them an opportunity to ask questions. Next, when we look at this one, the same thing. I would tell the patient, all right, your water gland's working, maybe a little too well. We've got an overproduction of water. When we look at the lid margin, there's some rosacea on there. You see the vascularization, but look at all this bacteria. It's on the bottom lashes, it's on the top lashes. And these little oil glands are not functioning the way they should. I'm not getting any oil out in this picture. And you can see that my tears are evaporating more quickly. Now look at this. I can also see that over and over and over again, you're not coming down with your blink. See how this line is formed across the middle, and finally you blinked. This is a problem because then you're not milking these oil glands, and eventually they end up clogging up and basically dying. The body dries them up because the oil's not being milked. And so I'll show you what normal looks like and how you compare, but we really got to get this oil moving. There's some debris in the tear film, not too bad, but we just have a lot of inflammation. Look at this image, look at this lid margin, how it's thick and rolled, and the redness on the eyeball. Little tiny bit of staining, not much. Ultimately with this patient, we are going to take care of that blepharitis, right? We're going to get them hypochlorous acid, maybe at-home blepharoexfoliation. This patient needs some anti-inflammatory. So I would start out with IPL, but ultimately they may also need something thermal evacuation to empty these glands out so we don't lose more. So just for the sake of time, I'm gonna keep going and kind of walk through my diagnosis and maybe my treatment without telling you exactly what I would say to the patient, now that you've heard it 3 or 4 times. So this patient, we've been treating them. Look how good they look. We don't have the thick rolled lid margins. We don't have the really red eye. The inflammation's very controlled, and the patient is actually asymptomatic. This is her annual dry eye eval. However, on each lid, I lost 1 gland. Now, this bothers me, right? I don't want to lose any glands. Now, she has plenty, which is great, but what was my recommendation to her? I showed her the old and the new and showed her that she lost a gland in a year. Showed her that our inflammation was under control, but that we have to do something here. And so we're scheduling basically a thermal evacuation to get better movement, because you see here the oil is not coming out on its own. So even when a patient is asymptomatic, even when they're well controlled, this is a beautiful tool in helping them see it and know, all right, I do need to do something. A couple just cool comparisons that I wanted to show you. The effect of monocular LASIK. Look at the difference here. Both eyes have a loss of oil glands, but yet this one had LASIK, and look at the integrity of that cornea and how much it's compromised versus the other one. And we wrestled with that epithelial defect for quite some time. Both of them had bacteria, both of them had meibomian gland loss, but the big difference here is the LASIK on that right eye. And then next, monocular meibomian gland loss. Look at the difference here. Look at how light sensitive this patient is. They've got basically the same inflammation along the lid margin, same rosacea, but we have some glands here and almost no glands here. And what a difference that makes in their comfort and just level of and intensity of symptoms. Rosacea despite good meibomian glands. So I love showing you this because it really is case by case of what's the problem. And we got a little bacteria here. We definitely have rosacea. Look at this lid margin, how uneven it is, how meaty red it is, but it's skinny here, it's rolled, it just looks sick and inflamed. But yet we have good meibomian glands, and of course we've got a post-LASIK here as well. But look at the color here. Their glands are working. We've got oil coming out. We haven't lost many, but we have an inflammation problem primarily from the rosacea. And then allergy, look at the difference. This one is a puffy lid, but it's not sick looking the way this one is. See how uneven and just degraded that lid margin is versus this one. This is more allergic, glands are okay, a little bit of bacteria, but when you put it together with their symptoms especially, and you see it's more red, we have some mucus and staining nasally that we didn't have temporally. And then just another example showing you the inferior SPK, and this is a patient who's primarily inflammation, but we've got a significant oil gland loss as well. But look at the lid margin, how uneven it is. You see the epiphora, you see the lower lid lag, and this nice little eyelash coming in as an offender. And then last couple, this one we've got EBMD, we've got history of RK, we've got a lower lid lag. We're okay on tear volume, her water gland is working fine. We look at the lid margin, got a little bit of rosacea, not a lot of bacteria, tiniest bit of color coming in, but we see our glands are in desperate shape and we need to act aggressively in order to make sure we don't lose more. So this is going to be a combination of corneal integrity issues along with gland loss and a little bit of rosacea. And they're probably, honestly, they're probably all tied for first place. And then last but not least, this is a patient brand new to me. This was actually last week. And the key to this patient is she didn't have any symptoms other than photophobia. No pain, itching, burning, tearing, nothing really to speak of. Now you see she was over tearing, but she didn't really complain of it. Why did she have no symptoms? Because she's neurotrophic. And you look at this is a sick eye. Now, what bothers her is her doctor wasn't really set on referring her. Why? Because she was asymptomatic. So I've had to spend 2 visits making up and kind of defending him, saying he just doesn't have the equipment to see it. I'm sorry, he's not a bad doctor. But ultimately, we've got the rosacea. You can see it here on this redness picture. When we back up a little bit, we've got almost total gland loss on the bottom, very few glands on the top, and you can see the degradation on the inferior cornea. And this is neovascularization, it's nodular, and pretty much no feeling when I did the corneal sensitivity test. So make sure if you're bringing them back for a full dry eye eval, take your little cotton wisp and check their corneal sensation, because a lot of these patients, you cannot judge by their symptoms in any way, shape, or form because their nerves are not sending the message to tell them that they should be in pain. And this was the same patient, and I thought this was just a cool video to show you. When she blinked fully, so that first one was full, we had color, but look at all these partial blinks, no color, and then she's gonna go down all the way and look at the color that comes out. And I just thought this was an awesome visualization of how we explain to patients all the time. You've got to blink all the way in order to get that oil out. And then last couple points, this is my follow-up plan and basically my cheat sheet on this. After the dry eye eval, I want him to come back for a procedure 95% of the time. Maybe 5%, I want him to do a procedure, but we've got raging bacteria, and so I want to get that under control first, but then I'm bringing them right back. Usually, unless they are not eligible for IPL or it is truly a gland-only issue and not inflammatory, which is pretty rare, we're going to start with IPL as soon as possible. 1, 2, 3, 4. I want to do that before I go with thermal evacuation because I want my inflammation under control. I don't want the glands filling back up with thick meibum. So at the end of the 4th IPL, if they're unobstructed and happy, great, I'll see you in 6 months. And we just went down to a twice-a-year visit where we're doing IPL at each one. If they're unobstructed but not sure or not totally stable, I'll bring them back in 3 months. And I may or may not add a treatment here because it could be that I waited to add CEQA until after IPL. Maybe I was trying to get away without it. And let's say that they are obstructed. At that point, after we're at our 3rd or 4th IPL, I'm going to go ahead and do my thermal evacuation. At that point, they're doing great usually, and I'm going to bring them back in 6 months. Now, let's say they're not ready for procedure. It's a money thing or whatever the reason is, they don't want to do it right now. Then I'm going to add treatments, but I'm not seeing them back for 2 months at least, because even if they come back unhappy, I'm not going to change anything because it takes 2 months to kick in. At that point, if they're not completely happy, and they're not going to be, I'm adding treatment. I don't give it quite as long, 6 weeks. Come back, still need something, I'll add it. And this time I'm going to wait probably 3 months because they are doing better at this point. They're just not completely resolved. But each time I'm adding a treatment if necessary. And so it becomes quite a load of things they have to do at home and a lot more dependence on their performance and their perfection. When we go this route and they have IPL or other treatment, I don't have to have perfection at home. And finally, rules to live by. So screen everyone, every time, screen them. It creates accountability among your staff and yourself. Schedule them back for dry eval. Don't do it on the same day. Make a plan, set up your work list, empower your staff members to succeed. Look at your patient. How is the best way to communicate them? What else do they have going on? Are they depressed? Are they anxious? Are they not sleeping at night? What else is happening? Listen to them so that you can communicate best with them. Show them what you see with your 5M, and then tell them their options. Have those good, better, best options ready, and you guys decide together. This really changes the relationship. It creates a sense of partnership and just accountability to each other. It's not just about me providing an easy button for them. It's about them doing their role and their part, and me doing my part. And I know this was pretty quick and dirty, but if you want to go deeper, not just about the 5M and utilization there, but just about treating dry eye, about if this, then that, creating a protocol, marketing, staff education, patient education, training, billing, coding, forms, all that stuff. That's what we do at Dry Eye Institute. It's 2 days, very intense, no real breaks, and 2 days, only 5 to 10 people each time, so that it can be very, very customized according to who's coming. And that's it, that's all I have. So we've got 5 to 10 minutes left where we can answer questions, Carver, if there are any.
There are indeed. So I just wanted to remind everyone that you can go ahead and answer questions even now into that question box in the chat section of your GoToWebinar screen. And that brings us to our first question, which I think will be a fairly easy one given the numerous mentions of IPL that I saw. Do you prefer radio frequency or IPL?
If you're wanting to do dry eye, I would start with IPL. And then if you lead into aesthetics down the road, you could add RF, but as a first line dry eye, IPL is going to do better. RF is better at skin tightening than IPL. IPL is better at dry eye than RF.
Perfect. All right. Do you prefer doing the non-invasive keratometric breakup time, or do you prefer the fluorescein breakup time?
I do the non-invasive on my dry eye valve. That's about the only time I do it, unless we're really trying to correlate it to vision as a patient education means down the road. But I do my fluorescein video constantly. As I'm trying to train my technicians to do the acquisition, I'll have her do it on every single patient, just as a good training tool. But when I do my fluorescein video, I always have them blink several times in the beginning naturally. I tell them, it's a white lie, we're just getting ready. You go ahead and blink if you need to, because I don't want them telling me later that, oh, I was trying to keep it open. So on every fluorescein video, we're collecting all that data that I was telling you about earlier. Love it.
Perfect. Okay, just a reminder for everyone watching. This will be available afterwards, as a recording will be sent out to you via email, and it'll also be available in the Oculus webinar archive, probably about a week after tonight's presentation. Okay. You mentioned kind of some home debridement. What do you do in office and kind of at home for lid debridement?
Every single follow-up, every time this patient comes in, they are expecting me to do 2 things after I look at them. They expect me to debride the lid, and they expect me to express to see what's coming out. And they know that whatever happens there is an effect from it. So if I debride and there's stuff coming off, we're going to talk about it, and I'm going to have them apply hypochlorous acid to their lid margin or do eye wash, do something because of that. If I squeeze and it's thick meibum coming out, they know that, all right, we're going to end up adding a vitamin next time, adding something else if it's still thick, because usually they have a warning, right? I'll give them a chance to do more at home, but I'll tell them, all right, it's still thick. And I always tell them what percentage of the glands are participating and what's the thickness. Is it semi-solid or is it thin? And is it clear or is it not? So those are the 3 things that kind of roll off my tongue as I'm squeezing. So I'll squeeze and I'll say, oh, good, I got clear oil. Oh, I got nothing. Oh, I've got toothpaste coming out here. And then I give them a warning. All right, it's been a month and a half on this nutraceutical. We're going to give it another month. We're going to do our warm compresses, be real diligent at home, eat more fish. But if it's still thick when you come back next time, plan on this. So they know there's an if and a then. Oh, debridement in the office, sorry. I use the Carpecchi debrider from Brooder primarily. I don't numb, but I'm not digging. It's just for informational purposes. I want to see how much is on there. And then my forceps, I use the ones from Katina, and they're shaped like a little golf club. I also enjoy using my lid stick, so I will, especially on my dry eye valve, I'm always going to flip the lid, so I've got it out, and I might just debride with it. At home, I use new lids primarily, and get incredible results as far as the tear film cleaning up and the lid margin. If I'm going to do a warm compress, I use that IECO Tranquilize. And together they do phenomenally well because we've got a warm lid, take the heat off and do the massage and then do the cleaning.
Perfect. That was all answers to a lot of questions that we had. So thank you for that. All right. How long do you wait between applying dyes like fluorescein or lissamine green to the eye before imaging?
How long do I wait to apply them before imaging? So we do, on the Worklist, when I had my collage up, let's see, we do everything in the order it comes up. And we get to lissamine first. So here's the best way to explain this. Whatever test you want to do, you save it as your work list, and it's going to put it in the appropriate order for you. And lissamine green comes first, dab it along the bottom lid, blink, take my straight ahead picture, look up, lid margin, down, lid margin, and then we put the fluorescein in. Now the fluorescein is a tricky one, especially if your technician's doing the acquisition, because the timing needs to be right. If they drain really quickly, it's going to be too dark. You're not going to see anything as a tear film as far as breakup time. But if they have staining and the technician has too much dye in there, it's going to be this sea covering it and it hasn't had time to absorb. So really work with them on doing the fluorescein well because it gives you a wealth of information.
Great. Appreciate that. How do you integrate your Keratograph kind of information within EHR system, or do you just kind of use the recommended kind of printout?
The printout we do religiously on every single dry eye eval. We are not as good at doing it on follow-ups. Definitely use it on screenings. Back when I was doing routine exams, the EMR, I customized it so I could have all my documentation there, so I don't need to put the report in there. But what I love doing is we put it on the collage view and we take the screenshot of that, and that whole thing goes into the EMR. Now, this is especially useful for you if you're not constantly in the 5M. For me, every single exam, we're already in there. So I don't really rely on my EMR to look at my 5M stuff because it's my exam, it's part of it. Mm-hmm. But if I'm thinking like, let's say fundus photos, I'm not going to be pulling that up all the time. So if you're using it less frequently, then yes, pull it into your EMR, but do it as a collage photo so you can get an absolute beautiful status of what that patient was that day.
Perfect. I think Oculus might have a preferred answer to this one. Do you have like a K5 for every room, or do you just have one in your pre-test room that everyone goes and sees? I know Oculus would really like everyone to have 50, Keratographs, but.
So to be honest with you, I have the Pico stand where it is hooked into my chair and stand. So there's one chin rest and I can slide back and forth. Good and bad. So you think, okay, for a solo doctor, that's great, I can operate it. That's kind of our workup room now because my technician is running it. I'm looking at it with the patient at a viewing station, but I have absolutely been tempted just as a solo practitioner to have a second one in the workup room. Here's what I'll say to this for everybody else. Have it in the workup room so that it can be a mainstream screener. If you have it in a special area of the office, that's great for dry eye evals, but you are absolutely missing the boat by not being able to use it as a screener. But when you have your dry eye eval, you can't have it holding up the room that has the auto refractor and the optomap and stuff in there. So that's where scheduling comes in. Have it in the workup room. Every patient gets the screener, but schedule your dry eye evals last before lunch and last before end of day. And that way, when the machine needs to be used for 6 to 10 minutes, there's not a routine exam right behind them waiting on the auto refractor. And you can get as many viewing stations as you want. So every exam room would be able to view it. They just can't capture it because the bowl's not in there.
That's a great explanation of how you have your practice set up and how practice should be set up. Kind of moving into more patient management, more of that verbiage stuff. I have two kind of final questions before we wrap up the night. So thank you for sticking with us, everyone. First, just how do you minimize no-shows for the dry eye evaluation?
Great question. I have a bulldog up front, and I'm going to tell you, she just started last year, and doggone if she's not moving to New York in a week from now. But it absolutely affected our bottom line. And the one thing that she did was she mitigated no-shows. And the way we did it was, one, we started booking out further. So we got more in demand and we're booked out 2-3 months. Well, all of a sudden, people are upset with that, and they're like, no, I need to get in sooner. And so, one, they value the appointment more, but it's not that. We have a cancellation list that is worked every single day. And so as soon as somebody drops off, she's on that cancellation list, and she's calling them, and the next one, and the next one, and the next one. And we tell them, all right, she wanted to see you in 2 weeks, but it's going to be 2 months. But if you go and fill out your paperwork and you've got everything ready, we'll call you and we can probably get you in a week or two. So it's really about creating value around that time, but having a very accurate cancellation list and letting people know ahead of time, here's what I need from you so that we can call you and get you in, and having somebody that's not afraid to call the same person over and over, keeping good notes. But that is the definite key. I've seen it firsthand.
That's a lot of great advice. All right, I have one final question for you tonight, and this is about just kind of struggling to manage dry eye patients, and just as patients, I have noticed a great influx of patients being harder to keep on dry eye over the last few years, where they need a lot of hand-holding despite the amount of information provided. What's your kind of recommendation to a doctor in that situation?
All right, this is very true. They believe that about 29% of dry eye patients have depression. Not only that, but they think like 50% of them have some sort of sleep issue. Well, then the sleep causes anxiety and stress and depression. All this stuff is balled in together. And I've had people at my Dry Eye Institute table going, I didn't come here to be a counselor. I don't want to do it if that's what it looks like. But here's the key. You can get a good outcome by treating their eyes and ignoring all that stuff, but you can get an amazing outcome without limits when you look at them more holistically and you address these things. However, you don't need to be a counselor. You don't need an hour and a half with each patient. You need resources. You need written resources, and you need to set the stage at the first exam going, look, we can make this better, but we're going to have a limit on how good we can get it unless we address these other things, and then hand them the resources to research and improve on their own, but create accountability. So when that patient comes in and their eyes have been feeling bad 2 weeks because they've been binge eating every night sugar, they are the ones confessing to you as opposed to looking at you going, I don't know why they're bad. Why are you not fixing this? And that's what you need. You need this partnership and this teamwork. Here's how we do it. I've got a 135-page patient education book, and it took a lot of time and effort and work. My Dry Eye Institute people get it. It's included, and they can sell it and pass it on to their patients, but I literally give it to every single dry eye evaluation. And at first I was giving it to them going, now if you're not going to read it, you bring it back to me. And now it is like my pride and joy because I know what it does. And it's exactly what that person is asking of. This can be daunting because you know enough to realize it's more than what you can handle and the time you have to handle it in. And so it's really about getting the right resources, setting accountability, and then sending them on their way with it.
Perfect. Thank you so much for all of your expertise tonight, both in the main presentation and answering all the questions. And I want to thank each and every one of you for attending tonight. Thank you so much for being here. It's been an excellent time.
Absolutely. Thank you, guys. Thank you for having me. I'm sorry Daisy was in the background distracting. I thought it would be more distracting to turn around and yell at her and argue with her. So thanks for bearing with it. And if you have any questions or want to reach out to me, go to contact us at Dry Eye Institute, and I'm there.